now we are going to look after bone mineral metabolism. Here we will look at some important regulators of bone mineral metabolism, that are PTH related peptide, vitamin D, and FGF23. These are the most important regulators of bone, yet most confusing, and hence we will look after them one by one. So starting with PTH. PTH is parathyroid hormone which is secreted from chief cells of parathyroid gland, and this PTH is an 84 amino acid compound which includes 1 to 7th amino acids which are active majorly, while the remaining 8 to 84 amino acids have action based on 1 to 7. Now this parathyroid hormone, it has a very short half-life of just 2 minutes, and that's why we measure parathyroid hormone along with other calcium, phosphorus, and vitamin D and ALP together, because whenever PTH rises or falls, these levels of other hormones will also rise or fall, and hence we have to measure them concurrently and not separately. So if you look after parathyroid hormone per se, the major regulators, which are the regulators of the hormone, so mainly it is serum calcium more than vitamin D, more than FGF23, and among calcium also it is the hypocalcemia which is a major regulator when compared with hypercalcemia. When we look after actions of parathyroid hormone, so majorly it acts upon kidneys, GI tract, and some miscellaneous actions. So majorly in kidneys, parathyroid hormone stimulates the enzyme 1-alpha hydroxylase. This enzyme is there in the formation of active vitamin D3. So number 1, it stimulates the enzyme 1-alpha hydroxylase. It increases calcium absorption in renal tubules. So how does it increase calcium absorption? So it increases the vitamin D dependent absorption of calcium via TRPV5/6 receptors in the distal convoluted tubules of nephron. And thirdly, it inhibits phosphorus absorption. And how does it decrease phosphorus absorption? By inhibiting or reducing the sodium phosphate transporter quantity and function in the proximal convoluted tubule. So these are the 3 major actions of parathyroid hormone in kidneys. Now that is, it stimulates 1-alpha hydroxylase, increases calcium absorption, and inhibits phosphorus absorption. Now we look after its actions in GIT. In GI tract, it increases calcium absorption from the gut. Whatever calcium is taken in diet, it is absorbed in the gut via TRPV6 receptors, and this action is indirectly mediated by vitamin D3. Whereas if we see this calcium absorption in kidneys, this is directly dependent on vitamin D. And looking after the miscellaneous actions, so there are some miscellaneous actions performed by parathyroid hormone. So they are, it inhibits sodium and water absorption in the renal tubules, it decreases glomerular filtration rate, it increases renin release or secretion, and it increases renal gluconeogenesis. And this is the reason why patients with hyperparathyroidism have glucose intolerance, or they have propensity to develop diabetes mellitus. So because parathyroid hormone causes increased renal gluconeogenesis. So this was in nutshell about the major actions of parathyroid hormone. We have seen it in kidneys, in GIT, and the miscellaneous actions. And the most important regulator is serum calcium, and that too hypocalcemia stimulates release of parathyroid more as compared to hypercalcemia. Next we move on to parathyroid PTH related peptide. So parathyroid related peptide, it is not parathormone, but it binds to the receptor same as that of parathormone, to receptor same as that of parathyroid hormone. So the receptor is PTH related receptor 1, PTH receptor 1. This is the receptor where these peptide binds. Now actions, when we look after actions of PTH related peptide, so I must say it first that it has no action on 1-alpha hydroxylase, which was the first action we have seen in parathormone, that it stimulates the enzyme 1-alpha hydroxylase. We have seen here it stimulates the enzyme 1-alpha hydroxylase, while PTH related peptides has no action on 1-alpha hydroxylase. That means it does not increase the production of active vitamin D. Other actions of parathyroid related hormone is it stimulates chondrocyte proliferation. It stimulates chondrocyte proliferation in the growth plate, and that is the reason that it causes increase in the size of growth plate. Also, the fetal calcium transport across placenta, the transport of calcium from mother to fetus across placenta, which happens during third trimester, and that is stimulated, or we can say facilitated by parathyroid related peptide. Also, it increases calcium release or excretion, we can say, in the breast milk. So these are the major actions by parathyroid related hormone, and it also it is also responsible for HHM, what is humoral hypercalcemia of malignancy. So this is mediated by parathyroid related peptide. The malignant tumors, they release the hormone PTHRP, and that causes hypercalcemia. And also there is a term known as lactation osteoporosis. Lactation osteoporosis, which is due to excessive PTHRP, PTH related peptide, because this PTH related peptide, it induces resorption via rank ligand pathway. Rank ligand, you must be knowing, rank ligand is released by osteoblast, which stimulates the osteoclast. It makes the osteoclast active, and hence they bring about bone resorption. So via this rank ligand pathway, PTH related peptide brings about bone resorption, and it happens during the lactation, hence it is known as lactation osteoporosis. So this PTH related peptide is important for causing increased calcium and also mineralization of bone, as it causes chondrocyte proliferation in growth plate also. So there is one recombinant PTH related peptide, you can say it is abaloparatide, which is a PTH related peptide agonist, and it has been FDA approved for the treatment of osteoporosis. How does it act and what is its benefit in osteoporosis, we will see in the classes, in further classes on osteoporosis. Now just you remember this name, abaloparatide, which is a PTHRP agonist. It has been approved for osteoporosis. So this was all about PTH related peptide. Now next week we will look about vitamin D. It is another important regulator of bone mineral metabolism. As we know, vitamin D is synthesized within the body. How is it synthesized? The precursor for vitamin D. What is the precursor? It is 7-dehydrocholesterol, and it is present in the skin. And in skin, in the basal layer of skin, it is present. Basal layer of skin, also known as the Malthusian layer of skin. So there it is present, 7-dehydrocholesterol, in after contact with the UVB rays, the UVB sunlight of the we must remember the wavelength here, 290 to 315 nanometer during 10 a.m. to 3 p.m. duration. It is better because this wavelength, the light of this wavelength is available during this time. So this 7-dehydrocholesterol is converted to pre-vitamin D3, and this happens in the skin. Alright, this pre-vitamin D3 is now converted into 25-hydroxy vitamin D3 via the enzyme 25-hydroxylase. It adds an hydroxyl group to pre-vitamin D3 and forms 25-hydroxy vitamin D3, and this procedure occurs in liver. The enzyme 25-hydroxylase is present in liver. After this, there is formation of 125-dihydroxy vitamin D3, and this occurs by the action of enzyme 1-alpha hydroxylase, which we have studied earlier, which is stimulated by PTH, and this process happens in the kidney. So the enzyme 1-alpha hydroxylase is present in kidneys, and so our active vitamin D3, that is 125-hydroxy vitamin D3, is formed. This is the active form of vitamin D3, and the T half of this active vitamin D3 is just 6 to 8 hours. After formation of its active form, this vitamin D3, it goes and activates other cells in the bone, it activates or it helps immune cells to build immunity, it goes into liver, and the rest of it is inactivated or either excreted. Most of it is excreted into bile and then the rest into kidneys. So this is the fate of vitamin D3. Here there is one catch point, that is this 1-alpha hydroxylase enzyme. That is very important to remember. One thing about this enzyme is that this enzyme is overexpressed, or we can say it is overstimulated in granulomatous diseases. And what are the granulomatous diseases that you know? We can say the most important is sarcoidosis, tuberculosis, or amyloidosis. So these diseases, it causes stimulation or overactivation of 1-alpha hydroxylase enzyme, which is responsible for increased vitamin D3 and hence hypercalcemia. Alright, and the inactivation of vitamin D3, it is brought about by the enzyme 24-hydroxylase. This is also a thing to remember. 24-hydroxylase enzyme brings about the inactivation or excretion of vitamin D3. And whenever there is a patient of HIV and he is on treatment with efavirenz, so there we must know that this efavirenz is a potent inhibitor of the it's a potent stimulator of the enzyme 24-hydroxylase, which inhibits vitamin D3, and hence in patients of HIV on the treatment with efavirenz there will be vitamin D3 deficiency. Now this is the formation of vitamin D3. After formation, we will look after actions of vitamin D3. Vitamin D3 also has actions in GIT, in kidneys, and over the bone, and its action over PTH. So in GIT, it increases calcium absorption, it increases phosphorus absorption. So both the minerals are absorbed in GIT via vitamin D3. In kidneys, it increases calcium and phosphorus reabsorption from the renal tubules. So these are also increased via vitamin D3. In bone, vitamin D3 increases mineralization. Mineralization is done by vitamin D3, but it is done only if it is pulsatile release or pulsatile increase in vitamin D3. If there is persistent elevation of vitamin D3, remember this bone will undergo resorption instead of mineralization. So persistent elevation of vitamin D3 as well as PTH causes bone resorption. And the action of vitamin D over PTH is that it decreases the secretion of PTH. So vitamin D3 decreases the secretion of PTH, because if vitamin D3 is adequate, PTH will not release. So this is about vitamin D3, and the last thing that we are going to discuss is FGF23. So FGF23, it is a molecule which is produced by osteocytes. Osteocytes produce FGF23. It is a 251 amino acid compound, and the receptor for FGF23, the receptors are FGF receptors numbered 1, 2, 4. These are the receptors over which FGF23 acts. And now looking after the actions of FGF23. So we know over phosphorus, the major action of FGF23 is it increases excretion of phosphorus via sodium phosphorus transporter, and hence it is phosphaturic agent. Phosphaturic agent. So it decreases the levels of phosphorus. Upon vitamin D, if we look after FGF23, so it inhibits the enzyme 1-alpha hydroxylase, and hence it decreases the vitamin D levels. Also, it stimulates 24-hydroxylase levels, and we know 24-hydroxylase is inactivates vitamin D. So overall, it decreases vitamin D levels. Next, over PTH, the action of FGF23 is that it decreases PTH release from the gland. And lastly, on calcium, so FGF23 increases calcium reabsorption from the kidneys. So in a nutshell, if we look, it decreases phosphorus, it decreases vitamin D, it decreases PTH release, and it increases calcium. These are the actions of FGF23. So whenever there is FGF23 excess, what do you think? What will happen if there is increased FGF23 levels in blood? So whenever there is excess, there will be decreased phosphate levels, and this will lead to rickets, because in rickets, for development of rickets, phosphate is the major agent. So in children it will cause rickets, while in adults it will cause osteomalacia. For growth plate, phosphate is an important agent, so FGF23 decreases it. And if FGF23 is low, if there is deficiency, so it will lead to increased phosphate levels, and increased phosphate levels will lead to increased calcium phosphorus product, that will lead to calcification at ectopic sites, and this calcification, that is ectopic calcification, will settle in the periarticular regions, most prominently in the periarticular region, and that will lead to tumoral calcinosis. So this calcification, it appears like a tumor, hence it is known as tumoral calcinosis. So these are some of the points related to FGF23.